Thanks, Jared. These are my disclosures. We observed over the last basically 2 decades a decline in the number of open surgical repairs, which has even been more aggravated since the last decade with the advent of complex endografts. I will focus on the next few minutes on the treatment of thoracoabdominal aneurysms. This is certainly one area there is a lot of room for improvement. You can see here the main players in the thoracoabdominal area dating back from 4 decades since Dr. Crawford, and you can see that there is still room for improvement in just the early mortality. And when we look at national data, there is a tremendous association with surgeon volume and hospital volume, and the mortality average is 26% in Medicare patients for low volume and 15% for the high volume operators. 2 years ago, I participated along with several colleagues here in this meeting in the American Heart Association guidelines for aortic disease, and you can see that for patients that have heritable thoracic aortic disease, open repair is the first line of treatment. However, on this document, endovascular now appears as an option for patients that have a suitable anatomy and in centers that have the expertise and, importantly, the access to these devices. In our case, we started this nearly 16 years ago with physician-modified grafts, which now became a fever around the country. And now with over 850 implants, most of these cases are done with manufactured devices. It's interesting to see what happens to a center when you have a dedicated complex endovascular program. We observed this at Mayo. You can see here that the proportion of endovascular cases significantly increased, taking over 80% of the thoracoabdominal aneurysms. You also see that those patients that are referred to open surgery are younger, more fit, and end up having improved results. In this propensity analysis done by Dr. Ng, it's unquestionable the benefits of endovascular early on. You have less mortality. Pretty much every major adverse event declines in 3- to 4-fold, including early reinterventions, more dismissals home. The patient survival, actually, despite the fact the patients are older, when you match for risk factors, is nearly identical. And surprisingly, the rate of cumulative incidence of any secondary intervention is also similar at 5 years, with no difference. The United States ARC joins 10 sites in the United States that have prospective non-randomized studies. This truly represents the highest level of evidence for this technology, because these studies are internally monitored, audited, adjudicated, and reported annually to the FDA. These are the 10 sites in the US, and I'll share with you a little bit of our data since I moved from the Mayo Clinic to Houston. And for this analysis, I included not only the IDE patients, we included those that were deemed too high risk for the IDE, that were treated by PMAGs or other therapy. So now with 207 patients here in Houston and an overall cohort that nears 700 patients, we maintained an overall 30-day and in-hospital mortality of 1%. And you can see here the major adverse events of dialysis in a minority of patients, major stroke, and permanent paraplegia also in a very low rate. This year we published with Dr. Huang at the Circulation an analysis of 1,000 patients done electively in the US ARC. And in these 10 sites, we were able to maintain an early mortality of 2.7%, which speaks for the reproducibility of the technique in experienced hands. It's a very effective technique. We're trying to prevent patients from dying of aortic death primarily, and you can see the cumulative incidence of aortic death at 5 years is below 4%, and that counts the early mortality rate. Also, we're trying to prevent rupture. The cumulative incidence of rupture is 2.7%. The average size of this aneurysm is 6.5 centimeters, so we would expect a rate of rupture at 5 years of over 50%. Of course, the limitation is the rate of secondary interventions, which is high at 40%. These patients do need a lot of maintenance for these very complex stents. The majority of these are minus procedures. You can see here the mortality in the 10 sites. We're very proud of our mortality rate, which is low. And the next chapter in the next decade is going to be centralization of this. You can see the discrepancy here from the VQI data to the US ARC data, with a threefold higher mortality in the US in the VQI. And also the sites that have dedicated programs, so-called IDEs, and it doesn't need to be a manufacturer ID, it can be a physician-modified IDE. You can see significantly lower mortality rate, not only early on, but late at 1 and 5 years, despite the fact that the IDE sites had more four-vessel cases, more thoracoabdominal cases, and higher complexity. Finally, failure to rescue is very important. So once a patient has a complication, you have to rescue that complication and have them survive the hospitalization. So I'll show you here an international study with 27 sites, and I think we are at site number 27 here. You can see the rate of complications is similar in the centers. It ranges around 10 to 30%. The difference is what happens when they have a complication. So look at here at site 26 and 27. Those are the two highest enroller sites. In site number 27, which was our site, we got a rate of complication of about 15%, and a mortality for those with a complication was around 5%. In site number 26, the rate of complications was 25%, but the mortality was over 60% in that site. So there's something going on with that hospital system in terms of the response system to the care of these patients. But unequivocally on this study, the centers with lower volume and the surgeons with lower volume had a higher rate of major adverse events. We're seeing in several guidelines the recommendation of multidisciplinary aortic teams, and most importantly, the recommendation of referral to high-volume centers performing ideally greater than 30 to 40 aortic procedures. And I would say by centers now also dedicated teams, because the surgeon volume is equally important. That's echoed also by the recent European course. So to finalize, what constitutes a comprehensive aortic center? Well, you have to have a functional multidisciplinary team, which means you have to get along with cardiac surgery, with cardiovascular medicine, with interventional radiology, medical genetics, without turf. You have to have the infrastructure, hybrid rooms that are cutting edge with dedicated imaging. You have to have access to the devices, which means in the United States having clinical trials. Now, we'll continue to have it because, one off-the-shelf device does not solve all the problems. You also have to have a dedicated inventory, a research team to assess your results and improve on your outcomes, and also education. Thank you very much, guys.